Okay, this is going to be the continuation of your wound care, and we're going to be going into care and treatments for wounds. So we have adhesive strips, which is one type of closure device. These are used on your closed superficial low tension wounds like skin tears or lacerations. And we close the skin on the wound that has been closed subcutaneously to aid in the reducing of scarring. It gives additional support to the wound after sutures or staples have been removed. The adhesive strips are often kept in place until they begin to separate from the skin on their own. And we used these when we were in lab, right? Those were those little sticky strips. And then we have sutures. So the traditional wound closure is considered sutures, AKA stitches. Suturing creates a whole bunch of small puncture wounds along the track of the actual laceration or the incision. There are several types of suture materials available. We can have absorbent sutures, and these are used in your deeper tissues. So things to close an organ or an anastomosis. An anastomosis is when we connect two tissues together. Because they're made of material that will gradually dissolve, there's no need to remove these absorbable sutures. And then we have non-absorbable sutures. So these are placed in superficial tissue. They're going to require removal, and nurses are able to remove them. And then we have surgical staples. So staples are made of lightweight titanium, and they provide a fast, easy way to close an incision. They're associated with lower risk of infection and tissue reaction than sutures are. The downside of staples is that some wound edges are more difficult to align. And the most common sites for stapling are your arms, legs, abdomen, back, scalp, or bowel. Hands, feet, neck, and face should not be stapled. And then we have surgical glue, which is safe for use in clean, low tension wounds, and it's ideal for wound closure method for skin tears. Collaborative wound treatments that we can have. So your collaborative treatments are necessary for wounds that will not heal despite aggressive care. Such treatments include surgical options such as debriding, skin grafts, secondary closure of wound, and flap techniques, which would be a partially detached tissue placed over a wound. And those are used for very complicated wounds. We can have hyperbaric oxygen therapy. And this is when we administer 100% oxygen. And we can do this to the pressure to the site, or we can do it in a chamber where the patient would breathe in the 100% oxygen. And we know that oxygen concentration in tissue will stimulate the growth of new blood vessels and enhance white blood cells actions. Hyperbaric oxygen therapy also promotes the development of fibroblasts, which will aid in our wound healing. We can also have platelet-derived growth factor that augments the inflammatory phase of the wound healing and accelerates collagen formation in the wound. Our diversity considerations, so our lifespans, ethnicity, disability, and morphology all can play a role in our wounds. So with lifespan, we have chronic wounds that can result in the inability to work and patients that will lose their independence. And this can happen in all ages. A significant financial burden may also be incurred from the costs associated with the treatment of wounds. For ethnicity, full thickness wounds, especially those to heal by secondary intention, as with stage 3 and stage 4 pressure ulcers, demonstrates a loss of certain epidermal structures that would include your hair follicles, sweat glands, and melanocytes. So this loss can be permanent, and these patients can have a localized loss of skin pigmentation around the color at the wound. They're also more prone to have keloids, which are scars that grow larger than normal and have a smooth rubbery appearance. The areas of hypo or hyper pigmentation are more common in darker pigmented patients. Disability, patients with disabilities that cause difficulty with mobility or sensation or sensory perception are at risk for development of pressure ulcers. Such disabilities include spinal cord injuries, peripheral neuropathies, and neuromuscular disorders. Morphology. Obesity is a risk factor for poor wound healing. Weight is not a good indicator of protein stores or nutritional health, so the obese patient can be deficit in the nutrients essential to wound healing. In addition, adipose tissue is poorly vascular compared with the epidermis and the dermis, and therefore at a greater risk for tissue ischemia. Because of the increase in mechanical forces that can be exerted on the edges of a healing wound, possible reduction in the ability to reposition oneself due to size, and common comorbid conditions such as heart disease or diabetes that may also be present. Obesity increases the risk of chronic wounds and poor outcomes related to wound healing. Now we're going into your nursing process with wounds. Remember, this is your ADPI. So when we're talking about our nursing assessment with skins and wounds, we want to do a focused skin assessment. How long has the wound been present? What do you think caused this wound? Have you ever had a wound like this before? Things of that nature. We would want to assess their Braden scale, and we know that the Braden scale is the numeric value for 6 risk factors related to impaired skin integrity. Evaluate 6 major risk factors. Those are sensory perception, moisture activity, mobility, nutrition, friction, and shear. The final score reflects the patient's risk. The lower the score, the more likely the patient will develop a pressure injury. A score of 18 or less for a hospital patient indicates risk. And then there's also the Norton scale, which assesses risk based on the patient's physical condition, mental state, activity, mobility, and incontinence. A low score indicates a high risk. Some have suggested that a Norton scale should be modified by adding categories for skin appearance, medication, and nutrition. So when we're assessing the skin and the wounds, this is a great list to go by. So we want to know the location. We need to describe the location in the wound in anatomical terms. The location will influence the rate of healing. Wounds in highly vascular regions, such as the scalp and the hand, heal more rapidly than wounds in less vascular regions, such as the abdomen and the heel. Location affects movement. Wounds that can be stabilized heal more rapidly than those in areas that are affected by constant stress of movement. Location can give us clues to the wound's etiology. A wound over a bony prominence could be related to pressure, whereas one on the bottom of the foot could be related to a diabetic ulcer. Your size. We want to measure the length and the width of the wound in centimeters. The NPUAP recommends using head-to-toe orientation, the longest length head to toe, and the widest width side to side, perpendicular to length, encompassing the entire wound. Undermining and tunneling assesses the wound edges for undermining or tunneling. We need to pay close attention to any tissue that appears to have separation, either in tissue type or plane, as frequently tunnels may be found. Measuring the depth and location of any undermining tunneling using the clock face as a guide. Appearance. Peri wound. Examine the skin surrounding the wound. Skin discoloration may indicate a hematoma or additional injury to the surrounding tissue. Look for maceration, undermining, crepitus, blisters, erythema, sloughs, or eschar. Drainage. We need to assess for the amount, the color, the presence of drains and odors, and we'll talk more about drain on the next slide. Erythema and swelling. Erythema may be a sign of irritation, indicating the surrounding tissue is in jeopardy. Pain is often an early sign of an infection. In the immune compromised patient, pain may be the only symptom. Nutritional status. Screen and assess the nutritional status of each patient admitted with a pressure injury. And whenever there is a change in your patient's condition, it should be assessed. Types of drainage, right? So we can have serous exudate. This is clean wounds, typically drain serous exudate. It is a watery and consistency and contains very little cellular matter. Serous exudate consists of serum, and this is that straw-colored fluid that separates out of the body when a clot's formed. So it'll have that straw-like color to it. Sanguinous is bloody drainage. Sanguinous exudate with deep wounds or wounds in highly vascular area. Serous exudate is bloody drainage. It indicates damage to capillaries. Fresh bleeding produces bright red drainage, whereas older dried blood is dark red-brown in color. Serous sanguinous is a combination of bloody and serous. And then we have purulent. So purulent, this is thick, often malodorous drainage that is seen in infected wounds. It contains pus, a protein-rich fluid with white blood cells, bacteria, and cellular debris. It is commonly caused by infection from phagogenic, which is pus-forming bacteria, such as a streptococci or a staphylococci. Normally, pus is yellow in color, although it can be blue-green if there's Pseudomonas that's present. Laboratory. So what laboratory assessments would we want to do on a patient that has a wound, right? So skin integrity, we would want to know what our protein levels are, our complete blood count, erythrosedimentation rate, glucose, thyroid, iron levels, coagulation, and wound cultures are all things that you would kind of want to hone in on for these patients. Your wound cultures may be ordered to determine the type of bacteria present. We can have local or systemic signs of an infection, so a suddenly elevated glucose level, pain, neuropathic extremity, or a lack of healing after 2 weeks in a clean wound, all may indicate the need for a wound culture. Culture may be attained by a swab, aspiration, or a tissue biopsy. And think back to that video we watched, and that gentleman said, if we biopsied a wound that wasn't healing, we could find out a ton of information. And that's because we can have colonized pathogens living on the surface, delaying our wound healing. So when we're talking about swabbing, this is the most common non-invasive method to attain a culture. We swab the area and we send that to the lab, and then they'll plate it, which is what you're seeing on this image, and we'll incubate it and wait to see what grows. When we do a needle aspiration of the wound, this involves the insertion of a needle into the tissue to aspirate tissues and fluid. Organisms present in the tissue can then be detected. Needle aspiration is an invasive procedure. It has to be performed by a qualified professional trained to perform such the procedure because it's at risk of inadvertent needle damage to tissue and underlying structures. And then we have tissue biopsies. This is the most accurate method for culturing a chronic wound. It has long been considered the golden standard. Tissue is removed from the wound edge by a specially trained provider and sent to a pathology lab or other specialized diagnostic centers. This is an invasive procedure. It creates a risk of sepsis, it will cause pain, and it will disrupt the wound's bed, sometimes increasing delay of healing. However, the results will be the most helpful for continued management and care. So we moved through all of our different things that we want to assess. Now we're looking at analyzing what we've assessed and coming up with our nursing diagnoses and our nursing concepts. So what's appropriate for people that have wounds? We're going to want to narrow in on either they're already having impaired skin or they're at risk for it, or there could be at risk for an infection, you can be at risk for pain and things like that. So all of that would be appropriate. Our interventions would relate directly to the types of diagnoses that we're trying or nursing concepts that we're looking at. So we know that anytime we have a patient that we're going to be doing an intervention on, whether it's cleaning, irrigating, redressing, we want to make sure that prior we're going to assess the patient's pain level. If we're going to be irrigating a wound, we're going to want to make sure that we irrigate a sterile wound with normal sterile saline, and that's the best to do that with. An ideal irrigation pressure will range from 4 pounds to 15. To remove material adhering to the wound bed, we need to use a 35 ml syringe attached to a 19 gauge angiocath and deliver the solution at approximately 8 psi. Pressures above 15 psi will actually increase the risk of driving bacteria deeper into the tissue, and it can also cause mechanical damage. Debriding a wound, this is the removal of the tissue or foreign material from the wound bed. It also helps remove cells that are not alive or that are alive but are not functioning from the wound bed and from the wound edges. We also remove necrotic tissue, exudate, and infective material, which helps simulate the wound healing and prepare the wound bed for advanced therapies or biological agents. So we have different types of debriding that can happen, and some people call it debriding. Debriding. So we have sharp debriding, and this is the use of sharp sterile instruments such as a scalpel or a scissor to remove the tissue. This method provides an immediate improvement of the wound bed and preserves granulation tissues. We have to monitor the patients for signs and symptoms of sepsis, so fever, tachycardia, hypotension, altered level of consciousness. After sharp debridement, we need to remember only specially trained providers can do that. Then we have mechanical debriding, which is performed via lavage, and then we use a wet to dry dressing, or your patient goes into whirlpool therapy. And you guys did your wet to dry dressings and labs. Then we have enzymatic, which this debriding uses agents to break down the necrotic tissue without affecting viable tissue in the wound. To use this, we need to clean the wound with normal saline, and then we apply a thin layer of cream and cover with a moist and retained dressing. You have to be cautious of where the cream goes, because remember, this is breaking down tissue and we don't want to put it on good tissue. And then we have autolysis, which is debriding this debriding uses an occlusive moisture retaining dressing and the body's own enzymes and defense mechanisms to break down necrotic tissue. This process takes more time than other techniques, but it's tolerated better by patients. The procedure involves applying the dressing and observing the fluid that collects under it. Wound fluid may be tan in color. The dressing is normally changed every 72 hours. And then there's biotherapy, which is also maggot debridement. This is when we're going to instill the maggots into the wound, allow them to digest the bacteria, neutralize the environment, promote normal tissue healing. This therapy is effective and simple to use, though containing the larvae within the dressing can be very problematic, and having patients agree to do this therapy can be difficult. So more interventions that you can do related to wound care would be to apply negative pressure therapy. These are going to be your closed negative pressure wound vacs. They're going to have the foam, and it's going to be sealed by an occlusive dressing. And then we're going to have a vacuum pump that provides continuous or intermittent suction. You have to be checked off by your institution to be able to apply a wound vac appropriately. And very often, most institutions will remove the wound vacs when they arrive so that they can do a full assessment of the wound. And then they'll have their wound care specialist come and reapply it. When we're dressing a wound, we can use a transparent film. This will allow an exchange of air and water vapor between the wound and the environment while preventing external bacterial contamination. They are useful for wounds with minimal or no drainage, and they're often used to address an IV site, right? So that we can see what the IV site looks like. And then we have gauze dressings. So some gauze dressings are impregnated with antimicrobial agents, medication, or moisture, and others contain petroleum to keep the wound moist. Gauze can be a combination of saline and medication. Gauze dressings can be used for packing large wounds, cavities, tracts, deep or dirty wounds, or heavily draining wounds. We have hydrocolloids, which are wafers, pastes, and powders. And when these are applied to a wound, the particles interact with exudate from the gel, and it keeps the wound moist. The dressing needs a protective layer to prevent friction and bacteria. This type of dressing is ideal for wounds with minimal drainage, such as a partial thickness wound or a stage 2 pressures. Hydrogels can come in sheets, granules, or gels with high water content, containing a jelly-like consistency that does not adhere to the wound bed. They're soft, they have a cooling texture, which promotes patient comfort. Hydrogels enhance epithelialization by providing moisture to the wound bed. They may also be used to soften Schlauth or Eschar in necrotic wounds, and they can be used in infected wounds. They also want to do supporting and immobilizing of the wound. Binders and bandages are used to hold the dressing in place, apply pressure to the wound to impede hemorrhage, and support and immobilize your injured area, thereby promoting healing and comfort. Before applying a bandage or a binder, determine the intended purpose of the application and assess the part being bandaged. We can also use heat and cold therapy. Response to heat and cold therapy depends on the area being treated, the nature of the injury, the duration of the treatment, age, physical condition of the patient, and condition of the skin. So when we talk about interventions, pressure ulcers have additional considerations, risk factors, assessments, and whatnot. So for our wound, for special considerations for your pressure injuries, nurses play a major role in prevention and treatment. Our nursing interventions for pressure ulcers do not need to be prescribed by a physician. They're solely nursing-based initiatives. Our pressure injury affects 15% of hospitalized clients. Pressure injuries are caused by unrelieved pressure to an area resulting in ischemia. It's estimated 1 million people in the United States have a pressure injury. About 15% of patients in hospitals, 10% in home care, and 20% in long-term care all suffer from a pressure ulcer injury. Risk factors for pressure ulcer development. So we have intrinsic factors, and these are factors that are internal, they're the patient. So they can have altered skin and tissue integrity. They can have oxygen issues where they're not getting enough oxygen from their chronic that are causing it. They can have immobility from an impaired sensation, from like spinal cord injuries, stroke, coma, poor nutrition, edema, aging. All of those things can lead to pressure ulcer development, along with poor nutrition and dehydration, which can weaken the skin and lead to pressure. And then we have our extrinsic factors. So extrinsic factors are things that we as nurses can prevent. or eliminate for our patients. So friction. Friction damages outer protective epidermal layer, decreasing the amount of pressure needed to develop the skin lesion. So every time we pull a patient up in bed, they can get a friction injury if we do not have, people actually lifting and they're just sliding the patient up. We can have pressure. Pressure injury most commonly develops over our bony prominences, but they can also occur under a cast, a splint, oxygen tubing, anything that is compressing the skin. So if a patient sits in a chair or a bed too long, they can develop it. Common locations is in the spinal sacral area, in the occipital area, in your scapules, in your elbows, in your heels. Then we have shearing. Shearing occurs when the epidermal layer slides over the dermis, causing damage to vascular bed. It commonly occurs when the head of the bed is elevated and the patient slides down, this causing the shear to develop in the sacral area. And then exposure to moisture, right? Especially in the form of urine or feces, this macerates the skin and also decreases the amount of pressure required to produce an ulcer. So your nursing assessments with your pressure ulcers, you're going to want to determine the stage, right? Is it stage 1? Is it stage 2, stage 3, stage 4? We classify it by the tissue involved. We know it's stage 1, this tissue is intact, it's just non-blanchable redness. And then we have our stage 2, tissue's not intact and it's red. This might be a blister, but it does not go beyond the dermal layer. Stage 3 will go beyond the dermal layer into the subcutaneous tissue, but does not extend into your bone, your tendons, your ligaments, your cartilage. Your stage 4 goes all the way down to those. Your stage 4 is going to involve all of those tissues. And then when we have stage 3 and stage 4, we can have an unclassified, right? Because if we don't know if that necrosis that's covering it is obscuring our view of muscle, bone, and tendon. So that unstageable, is it a 3? Is it a 4? We don't know, right? We can't tell what tissue is involved. Then our suspected deep tissue injury would be those things that are those dark maroons, and that can be confused in patients with darker skin complexion. Is it a 1 or is it a deep tissue, right? So we can use that push tool, which your book goes over. And then we have our interventions. So what are we going to do? Your top intervention is prevention. We want to stop it from happening, right? We want to make sure that we're doing meticulous skincare and we're doing good moisture control. Our patients are getting adequate nutrition. They're being frequently positioned every 2 hours. We're patting their bony prominences that are at risk. We're not leaving their heels on the bed. We might need a therapeutic mattress. And we need to do patient and family teaching, right? Because you might have a family member who says, you can't turn her, you can't turn her. And you need to explain, she's been on her bottom too long. I'm worried she's going to get breakdown. It's been 2 hours. We change our patients every 2 hours, You need to advocate for your patient and you need to teach your family and sometimes even the patients why we're doing this. And that concludes the second half of your wound care.